Well, thank you. I'm sorry if you were hoping for a different speaker, um, but I must have been cheap. I came 2 for 1. But thank you again for your attention. And these are my disclosures. I think I think we're all can agree that there's been an explosion of therapies in myeloma, and so this is just a nice sort of kind of way to illustrate just what's happened since 2000. So on the top, you really see the stage dominated by the
You may need
PI.
to share your slides, Jesus.
Okay. All right, so now you can see. Okay, so here, I'm showing you sort of what's been approved in myeloma since 2000, and it's really quite impressive, right? So on the top, you see it's all dominated by the PI and the IMiDs and the anti-CD38 antibodies, but really since in the last couple of years, you see that the BCMA-directed therapies are really taking center stage, with now 3 approved in the United States, and actually now in the EU 4 with teclistamab, the first BCMA bispecific antibody approved, and we're hoping that's coming to other countries as well. And so I showed you the slide before. Again, we've made lots of improvements in terms of response rates, and overall survival keeps improving, but the majority of patients continue to relapse. And one of the sobering things, I think these are still sort of appropriate here. On the left, you see that as patients relapse and they go to the next line of therapy, the expectation is that the median response duration continues to decrease. And then on the right, I think even more important, it shows the study from Britain showing that there's a significant attrition of patients moving from first line to second line to third line. So the majority of patients not necessarily being able to receive more than 2 lines of therapy. And so I think this is important in terms of using our best, putting our best foot forward and not reserving therapies for patients, in my opinion. So when we look at sort of the treatment landscape for myeloma, I think we can put a sort of a dotted line from the first, second, third line to fourth line and beyond. And so I don't have enough time to really talk about the sequencing of therapies in the early lines. I just sort of suffice to say that I think it's not unreasonable for us to be thinking of a PI and IMiD combination in first and even second line, with likely the addition of an anti-CD38 antibody, perhaps even, as you know, the quads coming in first line looking very strong. And then as we get sort of more towards the third line, we start sort of looking at next generation of PI and IMiDs with and without the anti-CD38 antibodies or other antibodies in our second and third lines. And there's a dozen or over a dozen studies now looking at triplets versus doublets, all showing an improvement to the triplets. So without a doubt, at least a triplet should always be considered or preferred over a doublet in the early lines of therapy. But I'm really going to concentrate on sort of the fourth line and beyond, where really the BCMA-directed therapies have taken center stage. So the first that was approved is belantamab mafodotin, and this is an antibody-drug conjugate against BCMA. So it's an antibody against BCMA that is bound to MMAF or monomethyl auristatin F. And as you saw before with polatuzumab, the idea here is that the antibody binds to BCMA, gets internalized, then MMAF gets released inside the cell. But this, what makes this different from other ADCs in the past in myeloma is that this antibody actually is functional. So you actually also have an anti-BCMA antibody that can elicit something, things like ADCC and ADC. So the DREAM-1 study was the original study looking at this ADC, and as you can see, there was a significant overall response rate of 60% with a median PFS of 12 months, and that looked quite impressive. But when you started looking at the patient population, you noticed that this study was mostly done in Canada, and in Canada at the time, the anti-CD38 antibodies were not approved. And so the DREAM-2 study really looked at the population of highest need, which was the patients who had prior IMiDs, PIs, and anti-CD38 antibodies. And so in this population, now you see a more attenuated response with overall response rates of 31, 34%, depending on the dose, and a median PFS of 3 to 4 months. Based on sort of kind of duration of response and doses, the 2.5 milligram per kilogram dose was chosen to move forward. What's interesting is that even though the response rates don't look quite impressive. If you look at the actual duration of response in those patients that do respond, it's actually quite nice, and with a median duration of response of 11 months and overall survival of 13.7 months. So this what got belantamab mafodotin approved after in the fourth line higher setting. In terms of toxicities, it's a very well-tolerated drug. The main toxicity that is new for us in myeloma is this keratopathy. So these corneal deposits that occur in actually the majority of patients, in over 2/3 of patients, with significant amounts of grade 3 and 4. And so it's an important toxicity to pay attention to. And because of this, it is recommended, and at least in the United States, it's approved with the caveat that a patient see an ophthalmologist or an optometrist before each dose of therapy. The good news is the majority of patients who did develop keratopathy had all the symptoms and all the deposits were reversible once you came off the treatment. The next type of therapy that for BCMA is, of course, the bispecific antibodies. And so here I just show you a cartoon of a bispecific antibody. You basically have an antibody that has two targets. One target binds to BCMA on the myeloma cell, and the other target binds to CD3 on the T cell, activates the T cell, redirects it to the myeloma cell and kills it. So there are several BCMA CD3 bispecifics in myeloma, teclistamab, REGN 5458, AbbVie 383, elranatamab, and AMG 701. I will not go through all of them. I am removing AMG 701. This is not moving forward, actually, so it's unfortunate, but I guess we have a lot of competition. But teclistamab really has sort of kind of taken the lead, and is the one that I'm going to show you some clinical data on, and is very close to approval in the United States, and again, it's been approved in the EU. So teclistamab was approved based on the MajesTEC-1 trial. And so this was a phase 1/2 dose escalation. Patients had to have at least 3 prior lines of therapy. They did not allow prior BCMA targeted therapy, which I think is important. Patients were treated intravenous and sub-Q. Patients also underwent step-up dosing, so they got 2 to 3 small doses before getting the full dose. And so the recommended phase 2 dose from this trial turned out to be 1,500 micrograms per kilogram subcutaneous once a week. So just kind of summary of their efficacy data. You see that the overall response rate on the left is 63%, with a complete remission rate of 39.4%, a VGPR rate of 59%. So quite impressive and deep responses. In the middle, you see the duration of response. The blue curve shows you the entire population with a median duration response of 18.4 months. And in the patients who achieved a CR or better, the median duration response has not been reached. On the right, you see the progression-free survival, and here we saw the median progression-free survival of 11.3 months with a median overall survival of 18.3 months. So again, the expectation in this population is median overall survival of less than a year and PFS of about 3-4 months. So quite impressive results. In terms of the toxicity, it's manageable for the most part. There is some cytopenias, although in my experience, this tends to be very early on and likely more reflective of burden of disease in the bone marrow of myeloma. Patients who have very little burden disease often don't have significant cytopenias, and then the cytopenias taper off later as the patient responds. CRS is very common. You see 72% of patients with cytokine release syndrome, but very little grade 3/4, and much less in my mind compared to the CAR T cells. The CRS tends to occur during the step-up dosing and rarely beyond the first full dose. So again, it's interesting and I think reassuring that with subsequent dosing, you don't see CRS. And neurotoxicity equally was quite rare. What is important, though, to pay attention to is infections. So remember, you are continuously redirecting T cells with these therapies. So these patients are getting weekly dosing of the antibody. And so they saw 76% of infections and 45% grade 3 or higher. And we're starting to see some atypical infections or infections that that are important, often seen sort of in the allo setting, kind of adenoviral pneumonias, and CMV reactivations, et cetera. So, and PJP as well. So I think it's an important thing to remember as our patients continue on these therapies. Of course, I'm not going to show you the CAR T data again, but just to suffice that we also have 2 BCMA-directed CAR T cells, idecaptogen viclucel and ciltacabtagene autoleucel. And just a reminder of the efficacy data with overall response rates of 73 to 98%, depending on the product. So I'm showing you here sort of a high-level comparison of the BCMA therapies, the ADCs, the bispecific, and the CAR T. So obviously we have at least one in each class that's approved for us. I think if I put them in order, sort of what the efficacy expectation is, I think we all can agree that the ADC has the less efficacious, and then the bispecific and the CAR Ts, I think, have the more powerful quick efficacy. In terms of duration of response, I think they move in that direction as well, although as the bispecific antibodies so far are showing some very durable responses, very reassuring. So it'll be interesting to see if that turns out to be even better than the CAR Ts. Although I think the early indications is maybe the newer generation of the CAR Ts will still be, at least in this patient population, will still be better, but remains to be seen. How it's given, I think it's important when you're trying to kind of decide between the different therapies. So remember, the ADC is given intravenous every 3 weeks until progression of disease. The bispecific is given intravenous or subcutaneous every 1 to 2 weeks until progression of disease. And the CAR T cell is a one-time treatment with no maintenance, which, as we discussed before, oftentimes leads to preference from a patient standpoint. Where can these be given? The ADC can definitely be given at all centers, including community centers. Right now, I think the bispecifics and the CAR T cells are still relegated to academic centers. The hope is the bispecific antibodies will be able to move into the community as well. But I think we need to sort of figure out a way to be prepared in how to mitigate sort of these initial toxicities in the first, and the dose escalation in the first cycle. But definitely, I think it has more potential to move into the to more centers than the CAR Ts themselves. In terms of notable AEs, obviously the ADC, you have the keratopathy, which is thought to be due to the MMAF. And then, of course, with bispecifics and CAR Ts, is cytokine release syndrome and neurotoxicity. Although I think if we go to CRS and neurotoxicity, I think the grade and sort of the intensity of the CRS and neurotoxicity is higher with CAR T versus bispecific. And of course, in terms of availability, both the ADC and the bispecific are off the shelf, whereas the autologous CAR T cell, you have to wait for the manufacturing wait time, and sometimes your patients cannot wait for 4 to 6 weeks before they get their treatment. So unfortunately, like I showed you before, most patients do relapse after BCMA. So the question is, can we sequence these therapies? And the short answer is we don't know. But we do now have some real world experience, and as well as some early data from clinical trials that are helping us hopefully understand this a little bit better. The first was the experience from UCSF, which was presented at the IMS this month, at the beginning of the month. In Los Angeles, they had 78 patients that were treated with BCMA CAR T, and 42 of those patients relapsed. And so when they looked at sort of what the treatments these patients received after a BCMA CAR T relapse, 8 patients received another BCMA CAR T, and they saw an overall response rate of 75%. 5 patients received a BCMA bispecific with an overall response rate of 60%. And then 7 patients received belamaf with an overall response rate of 29%. So the response rates of the bispecific and belamaf are actually not too dissimilar from what we saw in the clinical trials. And the CAR T actually also was impressive, although maybe not as high as we saw in the clinical trials. But still very reassuring that after a BCMA CAR T, you still can't treat with other BCMA modalities. When we look at the real-world data from the multi-center trial data from IDACEL that I showed you earlier, they also looked at patients who had had prior CAR Ts, yes or no. So the blue curves are the patients who had prior BCMA therapy, and unfortunately, they did not see a similar similar to what they saw at UCSF. Here, actually, there was an adverse effect of having a prior BCMA therapy with the median PFS, for example, of 9 months versus 5.8 months, and overall survival not reached versus 7.4 months, which, kind of goes, the question is, should we be using BCMA-directed therapies prior to CAR T? It's unclear. So now we actually have some clinical trial data, although it's very early. So CARTITUDE-2, I showed you cohorts A and B before. This cohort C, they treated 20 patients who had prior BCMA therapy, and they received cilta-cel. And so you see the breakdown here of the 20 patients, 13 had prior ADCs and 7 had prior bispecific antibodies. They excluded patients with prior CAR T. So again, these were non-CAR T BCMA therapies. So if you look at the overall response rate, you see that in the patients that had prior ADCs, you had a 62% overall response, all of them VGPRs. In the prior bispecific antibodies, overall response of 57%, 43% VGPRs, with duration of responses that were actually quite good. But clearly, the response rates are not at all comparable to what we saw in CARTITUDE-1, where it was almost 100% or 98% response rate. So definitely the treatment with the prior BCMA does make a difference, even with something as powerful as cilta-cel. So again, this is very early data, so we'll have to kind of wait and see a little more patients enrolled and also longer follow-up. What about bispecifics after BCMA? So we actually have some data now from with teclistamab. So I told you that MajesTEC-1 excluded patients with BCMA, but they actually had a cohort C, that was looking just at patients with prior BCMA. So they had 40 patients. And 70% of the patients had a prior ADC, and 37% of the patients had a prior BCMA CAR T. And so you see the overall response rate is 52% with a VGPR of 47%. In the ADC exposed, 55% overall response rate, in the CAR T, 53% response rate. So again, these are actually very nice numbers. The overall response rate in the entire population for teclistamab non-BCMA was about 63%. So still remains very active even after an ADC or BCMA. And we don't have a median duration of response just yet. And the safety profile was really no different than the entire population. So this maybe perhaps is telling us that we could use the bispecifics even after a CAR T or an ADC. Elranatamab, which is another BCMA CD3 bispecific, also had patients that allowed inclusion of patients post-BCMA. And so here they had 55 total patients, and 13 patients that had prior BCMA, 8 prior ADC, and 9 prior CAR T. And you see the overall response rate for all the patients was 64%, and the prior BCMA 54%. They did not break it down by type of prior BCMA, but again, showing that there are response rates in these patients. So in terms of sequencing BCMA-directed therapies, I think, the expression of BCMA, we know the expression of BCMA remains in the majority of patients who relapse. So we know we could use BCMA-directed therapies, and they technically can be sequenced. I think the early data shows us that sequencing is reasonable. Maybe the CAR T response rates are not as effective or not as good in patients with prior BCMAs. And I think that's a very important point from a standpoint of bridging therapy to your CAR T. I would definitely not use an ADC or any kind of BCMA-directed therapy prior to CAR T, given those results. The bispecifics appear to retain efficacy, and they may be better sort of as sort of the next line of therapy if the patient has had a prior BCMA instead of a CAR T. But I think ultimately, figuring out the mechanisms of resistance will be important to really help us determine the optimal sequencing. Just like before, obviously, maybe we don't have to sequence BCMA therapies because we have other targets coming in our path. And so these are the two sort of lead the way. There's bispecifics against both of these. So one is FcRH5, which is expressed really exclusively in B cells and myeloma cells. And so cevostamab is a bispecific against FcRH5 and CD3. And then on the right, you see talquetamab, which is a bispecific against GPRC5D. And GPRC5D is also mostly expressed in myeloma cells, although there is some limited expression in highly keratinized tissues and salivary glands, which you'll see predicts some of the toxicities. So if you look at cevostamab, on the left, you see that the majority of patients, when you see all the treated patients, this is their phase 1 dose escalation, is overall response rate is 36%. But when you just look at the patients sort of in the higher doses, or think of the efficacious doses, you start seeing overall response rate now closer to 60% with VGPR 33%. They actually had 33% of the patients had prior BCMA therapies, and the overall response rate for those patients was 63%. So again, showing us that there is significant activity even after BCMA therapy. The median duration of response is quite good at 11.5 months. And what's interesting with cevostamab, unlike the other bispecifics, is they had a limited duration of treatment. So patients stop treatment after 17 cycles. This is given intravenous every 3 weeks. So that's a year of therapy. And after a year, patients were stopped. And you'll see at ASH, actually this year, there'll be a presentation on what's happened to those patients, but we can tell you that patients maintain their response after stopping therapy. So that's actually quite encouraging. Perhaps we don't have to keep giving the bispecifics till progression. Similarly, for talquetamab, the Monumental 1 study has been reported several times and will be reported again at ASH this year. You see that they have 2 expansion doses. One is a 405 micrograms per kilogram subcutaneous weekly, and the other is 800 micrograms per kilogram subcutaneous every other week or every 2 weeks. And both doses are efficacious with response rate of 66 to 70% with a high rate of VGPR CR rates. 25% of patients have prior BCMA therapies, but they have not reported on these results, so we don't know what the activity is in these patients. The duration of response has not been reached, or the median duration response has not been reached. The toxicity is very similar in terms of cytokine release as we've seen with the BCMA bispecifics and the FcRH5 bispecifics. But here you do start seeing some on-target off-tumor toxicities. And so many patients do develop dysgeusia, dry mouth, nail changes, and rash, which can be difficult for some patients. The good news is that those symptoms are hardest at the beginning, and with time, even on therapy, they continue to improve, but they don't always go completely away until you actually stop the therapy. I showed you this before with the GPRC targeted CAR T. So again, now CAR T is developed against other targets, very promising. And then if you look specifically at the prior BCMA treated patients, it looks very efficacious with response rates of 75 to 80%. So in summary, I think in general, for patients, we recommend that you treat to maximum response, balancing the toxicity. In the early lines of therapy, I think triplets for sure should be chosen over doublets. And I didn't really go through that data, but that's just a summary recommendation. And definitely quads in the frontline setting are very reasonable. I think in the post-IMiD-PI CD38 space, the BCMA therapies are definitely your go-to treatments, as they're sort of the most efficacious at this point. And 3 classes are now approved or about to be approved. And so the question becomes, how do we sequence these? How do we choose between the 3? Which one do we use first? And I think, at least for now, until we know more, you really need to tailor your choice of therapy based on the availability, first of all, the disease characteristics, the patient comorbidities, and then ultimately the patient preference. In my mind, I think if a patient is a little more frail, I'm going to be probably leaning against from CAR T and maybe going more to the ADC and perhaps even the bispecific. But I think if you have a bispecific CAR T option, I would definitely choose that over the ADC, again, except for that patient that may not be eligible for those 2. From a standpoint of how to choose between the bispecifics and the CAR Ts, I think both are excellent therapies. And again, I will come down to what's available and patient preferences. Like I said, I have patients that will only take a CAR T, that will take nothing else because they want to have that potential for treatment-free period. I think it behooves the bispecifics to actually start looking at that durations of therapies that or treatment that does not continue to progression. We are starting to see that these after a limited number of cycles, we can see durable response rates. And so perhaps the bispecifics don't have to be given traditional way like other myeloma therapies. So I think more to come from that. And if that happens, I think that will really make them even more powerful in comparison to the CAR Ts from a standpoint of which to choose. I think, you know, perhaps once you decide which one you choose, you don't have to think about another BCMA therapy because the non-BCMA targets are already underway, and it's intuitive that perhaps going to a different target makes more sense. And so definitely the GPRC5D and FCRH5 targets are leading the way, but there's many others that I didn't show you, which is wonderful, and because of that, I think the future of myeloma remains bright. And so with that, I'll stop and thank you for your attention.